Great presentation. Thank you so much. You know, one of the things that I like to think about when talking about surgical correction for DFUs, some people like to go in and do a straight osteotomy of that metatarsal head, while others like to do a straight metatarsal head resection. Have you any experience with one or the other? And what do you think about potential results from this?
I think for considering an osteotomy versus a midhead resection, you have to look at which metatarsal you're going to address. So I consider it much more in the first metatarsal than I would in the lessers. And even in the first metatarsal, sometimes in these neuropathic patients, the osteotomy is going to be something that may, you have to heal an osteotomy, right? And as opposed to in patients that they don't have the best protoplasm, their A1C maybe not the best. We're going to look at vascular status and go through that, but doing a simple med head resection of all five or one or the other, to me more so is what I'll lean for in these ulcer patients.
Mhm. And what about transfer lesions that you may see, especially with somebody with a varus forefoot?
Yeah, so I'm more in the boat of doing more of the doing a pan med head resection than doing one a single head resection. Yeah.
Okay.
I'd like to add too that I think that when you have a patient too with diabetes as well and glycosylated tissues, and you're going to fix the equinus deformity with that plantar flexed first ray, and if it's a flexible deformity and you do have that hallux, that contracted hallux, have you ever been able to have, and of course the patient candidate has to be, the patient has to be the right candidate, but also doing a Jones-Tino suspension.
Yep.
And also doing the equinus, taking care of that as well. Have you had success with that, or do you like that procedure, or have you tried that as well?
No, that's a great question and a great thought. Purely being honest with you, I haven't done a Jones, but I have done for one of those, if it's a flexible plantar flex first ray, I actually have done a peroneus longus tenotomy and then tenodecit to the peroneus brevis. So as we know, the peroneus longus inserts at the base of the first metatarsal and is a plantar flexury force there. And so taking away that moment and then not losing the strength of that by tenodecing it to the brevis along the lateral aspect of the foot, I've had success with, just anecdotally. And there's actually a paper in JBJS that I wanted to include here, talking about, but obviously I ran over time, but the releasing the band, one or multiple bands of the plantar fascia within the arch to relieve plantar pressures under the metatarsal heads for these patients that showed some success, but so something else to consider.
Great. I love the lecture. Thank
Great.
you.
Thank you so much.
Thank you, guys. Yeah.
Were there any questions?
Yeah, I have a question. So those tenotomy for the flexible hammer are great procedures. My question is, in a diabetic population, are there if you can't feel the pewter pulses, are you still going to proceed with the procedure, or do you do some advanced vascular study before you proceed with the procedure to prevent necrosis and gangrenous of the wound?
Yeah. Now, and that's another great question and something I wish I would have had more time to get into, but that's a clearance, vascular clearance is something I get on even the most minor, if you will, of these procedures like a percutaneous toe tenotomy. As you and I have both seen it, working with a population similar to this, these patients' toes can turn gangrenous with even the smallest incision, even between the two digital arteries. So we'll get vascular clearance, we'll get to toe pressures, non-invasive waveforms, and PVR. So, yeah.
Yeah, I think that's important. Like I've seen some patient that come to me from outside physician, they would do procedure and they oftentimes overlook the vascular status, and it's something that you can so easily get done with like a non-invasive ABI, you know.
Yeah, yeah, definitely. And even not, this is off the topic of this discussion, but just I've seen patients that came in that had a simple ingrown toenail removed that turned south because
Yeah.
their perfusion wasn't adequately checked. So
Yeah, exactly. And that put an amputation.
right.
So can I, if I can make a point, just emphasize, Dr. Johnson, what you were talking about. I think it's not just an ankle brachial index that's important, but it really is also knowing about the toe brachial index and actually forefoot perfusion. So a lot of individuals will stop with just an ankle brachial index. It's really insufficient if you're trying to heal a distal wound, but it's also insufficient if you're considering a surgical management of that.
Yeah, absolutely. Thanks for bringing that up. That's something that we have, stressed the importance of, at least in our practice here and at our institution, is that these diabetic patients, the ankle brachial index is generally not reliable. You know, as they get the calcinosis of that tunica media in their arteries, and you'll get falsely elevated ABIs. So getting the measurements out at the very distal aspect of the foot, you know, the toe pressure and the toe brachial index is paramount.
No, absolutely. And you see a lot of times that actually doesn't happen as frequently as it should. And so it's nice when we're in this type of forum where everyone can kind of discuss that, remind everyone how important that is, especially for our podiatry folks.
Yeah, you bet. And almost like preaching to the choir, I guess, here, but it's good to hear everyone else reinforce that. So
we also have another topic coming up that's going to be the effect of antibiotics on bone biopsy with David Trong. But before I introduce him, I just wanted to also let you know we have two panelists here. Demir Jozic, he's Chief of Podiatry from New Mexico VA Healthcare System, as well as Dr. Carmen, and that was who was just speaking. She's a subject matter expert from Cleveland, and she is a vascular medicine specialist. So I got a chance to introduce them as well, and I'll introduce the speakers individually as we go. But it's just we got a great panel here, so I want to make sure everyone was recognized. So Dr. Trong is actually my colleague at VA here in North Texas, and he is the inpatient specialist along with me, and so he does a great job, and we're going to give the floor to him.